I've had an interesting career, and part of it has exposed me to the issues that we sort of address with advocacy, both at the national as well as at the state level. My initial experience with the American College of Chest Physicians meant yearly visits to the Hill, and it seemed to be a recurring theme. There never seemed to be anything different. Our asks were the same and nothing ever seemed to be done. So as I've come along through service on the North Carolina Medical Board and getting to know a little bit more about the local health needs, the whole issue of advocacy in conjunction with what the population health priorities are sort of become of interest to me. And when my opportunity to come to the leadership school came along and the project was proposed, and I said, well, advocacy seemed to be an area of interest, especially with something that seems to come up every year, which is the defensive scope of practice issue. And I wanted to sort of find out maybe a little bit more about it and where we sort of, as the rank and file in North Carolina Medical Society, as an advocacy organization, really thought about population health needs and where we should be focusing from an advocacy perspective. I did get permission from Sue Ann Forrest to show these slides. This is a White Coat Wednesday, and we're talking with one of our legislators, Greg Murphy, the only physician at the time in the North Carolina House of Representatives. And again, it was the same recurring issues that we're addressing, predominantly defensive issues, sometimes relevant to income or practice protection. And clearly concerns for viability of practice are things that we need to keep in mind, because practice is not always in favor of the person in private practice. One of the things I mentioned was my sister in private practice in Pennsylvania. She pays 5 times as much per unit dose for her vaccinations as the UPMC system does. And these are facts that you struggle with from day to day. Now, North Carolina does not do well from a healthcare perspective. We are below average as far as outcomes go. This slide depicts us in the red down there, maybe not too much worse than average, but certainly not high performing. And then within North Carolina itself, which is not quite average, there are areas, the dark areas, which from a outcomes perspective and access perspective do much worse than others. So there's some counties that probably do well above average for the United States in North Carolina, but there are many, many counties that drag our overall performance down to somewhat below average. And then aside from the geographic issues, we also have racial and ethnic health disparities, which have been defined, it's been studied, I think, and acknowledged, and we still have to address those as well. So the question is how? And we can propose increased number of providers of all sorts. We could potentially change the provider distribution within the state, or change the provider roles. How we combine these things and how we drive that process forward in a way that doesn't create conflict between all of the participants in team-based care these days is really a difficult problem. And I think that we really need to address the concerns and the thoughts of the practitioners to get what we can get overall support from more than just one sector to move forward, and perhaps use that to drive our advocacy initiatives at the state level on an ongoing and a positive basis to framework then maybe the minor adjustments that one part of the provider panel might need to support their ongoing viability. So what I did was to ask the North Carolina Medical Society leadership to help me with a survey, and you guys have heard that before here, and understanding that surveys have problems, attention spans are short, and the number of questions can lead to frustration, and the best surveys, you may have a 10 or 20% response rate. We surveyed leadership from the North Carolina Medical Society KIPL Leadership College understanding that there probably would be some bias there in the sense that they should have a better perception of population health perceptions and realities in North Carolina and how to perhaps improve overall health outcomes. So the general demographics were not surprising. We had a 41 to 50-year age group dominance. I was surprised that we had mostly urban, non-academic practitioners who responded, and these are both PAs, MDs, and DOs. They had a surprisingly narrow view of population health. The focus seemed to be on outcomes without really the concerns regarding distribution or social determinants of health. And then as far as wellness goes, which is sort of the flip side or the supportive side of population health, there seemed to be a focus on physical and emotional issues and sort of leaving out the other things that wrap around it, the occupational, intellectual fulfillment, environmental challenges for patients with respiratory disease, and so on and so forth. The other big surprise was that the providers thought that we had good access to primary care in North Carolina. That was very surprising because I think we have the data out there to support the fact that there are substantial statewide problems. Although people did acknowledge that compared to other OECD countries, globally the US population health outcomes were worse. The overall bias of the group was just increasing manpower and then in all areas, both physicians, nursing, PA staff, as well as focusing specific financial and institutional support to shift practitioners' interest to more rural areas. And interestingly enough, the scope of practice question, the providers felt that were surveyed felt that this was really much more of an individual or institutional, financially driven conflict and really didn't have much to do with access to care. So in short, we had this group of physician leaders that had a low recognition of access gap in North Carolina and a limited understanding of the concepts of population health and wellness. So that's I think, a fundamental background problem. And then when you add to it the fact that there's the belief that we have good access to healthcare in the United States, it really makes it important for us to perhaps see if we can't shift that, or close that gap of knowledge. And then the scope of practice conflict that seems to leap out at the legislature, there didn't seem to be the perception, at least in our group of surveyed physician assistants and physicians, that was something that was relevant to the actual access gap and that changes in scope would drive healthcare into closing that gap in the rural and underserved areas. I do acknowledge that we have a really low response rate here, and this is a selected group of North Carolina Medical Society trained leadership that we've surveyed, but it does certainly raise interesting questions. Perhaps a broader survey of North Carolina Medical Society members could be used to confirm these findings. But I do think that we need to address this gap in knowledge regarding population health. And I think that the general perception that training additional manpower and focusing financial help to place those manpower in the rural communities or difficult to access communities could potentially serve as something that if we advocate for as a positive thing with the legislature on an ongoing basis, that sort of framework would allow us then, whether you're a physician, a nurse, or a physician assistant, to address the short-term, maybe more immediate attention that you need with advocacy with a more favorable type of response from the legislature. I'm happy to take any questions. Thank you.